evening, everybody. Not good enough. Good evening, everybody. Thank you. I like hearing that. Way to go. Way to go. Thank you. So for those that don't know me, my name is Stuart Schlossman, and I want to welcome you to this event, being our second annual Memorial Neuroscience and MS Views and News partnered multiple sclerosis learning program. So I want to thank you all for being here. I'm sure that they appreciate it as well. All right, this event is solely sponsored tonight by Memorial Neuroscience, okay? And they're doing this because they want you to learn what it is that they have to offer the MS community. They have things that, if you're seeing other neurologists or general neurologists or otherwise, if you're living out of this county, living in another community, this is something that you might find interesting, whether it be with tonight's speakers or in general, everything that they have to offer from this comprehensive MS Center. I said that wrong. It's supposed to be comprehensive in the quotes, not the quotes before comprehensive. Our next presenter is Dr. Madiley Broz. She's a clinical neuropsychologist. She does neuropsychic evaluations, and she's fellowship with Neurology. She's a graduate of CAU. Where's CAU? Where? Okay, it's out of Miami, okay. Anyway, she's going to come on up and she's going to speak with you about some neuropsychological issues, and then we could all test your brains and come back and have questions. Dr. Broz will speak for 30 minutes, and then we will do 10 minutes again of Q&A.
Thank you, Stu, as always. Good evening, everyone. I'm very happy to be here once again. I was here last year and I really enjoyed this experience. Let me start. So again, I'll be talking about cognitive issues encountered with MS. Thank you. Alrighty. So, as you all know, cognitive dysfunctions is part of those invisible kind of symptoms that you guys all experience with MS, including that pain that nobody sees or the spasms. So cognitive dysfunctions, although not visible to other people, you do experience them, and you're probably the first ones to notice it even before it becomes visible to others. And we're going to go in detail about what I refer to as cognitive functions. So we're going to be talking also about the cognitive difficulties that are experienced as part of the normal process of aging that we all go through, and also those that are more clinically significant that might be actually suggesting an underlying neurocognitive or neurodegenerative kind of condition, such as dementia or early onset if you're young. We're also going to discuss the neuropsychological evaluation process and how these cognitive dysfunctions affect your daily living, so work and your home environment. And we will be discussing as well the psychological and social impact that these cognitive dysfunctions actually have on you and your daily living and what we can do about it. So first of all, let's discuss what that is. So it's our thinking abilities, okay? It's what nobody really sees, but we use on a daily basis from the time we wake up, okay? So short-term memory loss, for instance, slow processing, which is very common to MS, our ability to focus, sustain attention, divide attention, shift it. There's all different sorts of attention, and we have to assess that using a neuropsychological examination. So our ability to learn effectively and remember things, how we retrieve that information, that network, whether it's actually an inattention issue or a memory issue, we tend to differentiate, among that as well. Our ability to plan, carry out, and monitor activities, more usually it's described as executive dysfunctions, and it actually comes from your frontal executive skills. Our ability to think, reason, and solve problems on a daily basis, understand and use of language, like Miriam was referring before, like having word retrieval issues, not being able to express yourself or understand what others are saying, or reading the newspaper and comprehending what you're reading, having to read it a few times. We can capture that as well, and also figure out what is the pathological or the underlying cause of that. Your ability to recognize objects, be able to identify them, assemble things together, and judge distances, okay? So cognitive impairment, actually, it's very frequent. In the general population as well, it's just that it's not very thought about, or it's not really discussed, unless you bring it up to your primary care physician and you are referred to a neurologist. That's usually the first line in assessing this and identifying the symptoms. But it does happen in 65 to 70% of the MS patients. The degree tends to be mild to moderate. In the severe cases, they're very seldom, and it happens in less than 5% of patients, and it's when actually we see an underlying neurodegenerative process going on, such as dementia. The severity of your cognitive symptoms really depends on the lesion burden. So whatever we see on the MRI, depending on the location of that lesion, it's typically how your cognitive dysfunction is going to be translated or expressed. If it's in the left hemisphere, close to the temporal area, where the hippocampus is housed, then we are typically going to see memory difficulties. If it's in the frontal lobe, we see executive dysfunctions, disinhibition, and all of that. So in the process of normal aging, we expect to have some difficulties with cognition. However, when that becomes clinically significant enough to impair your daily functioning, like I said, your work-related activities or your ability to actually carry out your chores at home, then that's when it becomes problematic, okay? So normal aging, for instance, you have difficulty remembering information or details of conversations, but not being able to recall that information or those details is actually clinically significant. So it doesn't ever come back to you within a few minutes. Occasionally forgetting names of people. So if those names of people are actually people that are familiar to you, family members, friends, that you happen to know and see very frequently, that's also a significant change. Forgetting things and events. So it's actually common, but when you do it very frequently, again, on a daily basis, and that's significant, worried about your memory, and your friends are not, or the people that know you very well are not, then not a difficulty at all, or at least a clinical difficulty. But whenever you hear that your family members are worrying about your memory because they notice that you are having trouble, that most likely you are, okay? And sometimes part of that process is having that poor insight and your judgment to even identify that you have a problem with cognition as well. So my advice to all of you is to listen to the people that love you, that you have around you, your family members, because becoming aware is actually the first step in addressing this. So the physiology behind cognition in multiple sclerosis, I don't want to get too technical about this, but what you need to know is that if it actually affects your brain or any of the places, the locations of the brain, especially on the outer layer, the cerebrum, then it definitely, you will most likely have cognitive problems. So in multiple sclerosis specifically, we actually note a lot of cognitive deficiencies within the area of processing speed. And again, there is different sub-areas within this domain that is affected as well. And for that, we use multiple tests to assess this domain. So information processing is the most common cognitive dysfunction, and we see it in 30 to 60% of individuals. So for instance, all of a sudden not being able to complete tasks as fast as you were able to complete them before, or not being able to put together things in your head the way you used to do it before, fast to make decisions, and obviously motorically, we see also fine motor coordination issues, or that you're being slower than normally. That's very common. It's low processing speed in multiple sclerosis. So memory and new learning, more or less like half of MS patients do report memory loss and forgetfulness, and we find that in half of the patients that's actually true, okay? Complex attention, so our ability to shift and do multiple things at the same time, we see 25 to 35% of patients encountering that. Similarly with executive functions. So executive functions are our ability to actually plan ahead of time, initiate activities, and strategize in order to learn new information. So if I'm giving you a list of words, and I'm going to repeat it over 5 trials, I'm expecting for you by the second, third trial for you to be already implementing an effective strategy so that you can order that list of words and to be able to recall it later on, or even improve the total recall for all of the words that I'm giving you. The same thing with logical memory. If I'm giving you stories to remember, you should already be implementing something in mind, a strategy, in order for you to be able to retrieve that later on. So that's executive dysfunction, and we see inconsistencies in the profile so that we're able to determine if it's coming from an inability to strategize and put information in place in an effective way, or if it is really a true organic memory disorder. So visual spatial perception, word fluency, less likely, and like I said, widespread deficits within the severely impaired range, less common. What's not affected? So our intellect, okay? I'm not expecting for MS or we do not, neuropsychologists do not expect MS to affect your intellectual level, so your intelligence. Your reasoning will remain intact. Like I said, it's other functions that are affected, but your reasoning and your intellectual ability is normal. Long-term memory, so information from the very far past, it's typically not affected either. Conversational skills, for the most part, you're able to engage in conversations reciprocally. And reading comprehension, we see that less likely. Whenever we see any of these areas being affected, then we have to look at other options and analyze why you're having these issues when we're really not expecting you to have them. So I want to give an overview of what the neuropsychological evaluation is about, because I know oftentimes your neurologist refers you to the neuropsychologist, and then all of a sudden you hear that you need this evaluation and you don't know what it is about. So I want to explain to you. This is the first step actually in addressing your cognitive difficulties. So if you go to your neurologist and you complain of having some memory difficulties and that you're being slower than usual, you should have that checked out. You should go for a neuropsychological evaluation. The earlier, the better, because we consider that a baseline. So that's exactly where you are at that point in time that we're testing you before you even show significant deficits. It's very helpful for the neuropsychologist, because let's say that later on, over time, you start deteriorating cognitively. And if we have a baseline assessment to compare to, it helps me tremendously. Okay, or any neuropsychologist. So the evaluation process actually makes use of a battery of tests that are customized to you after you meet with me on the initial visit, okay? So depending on those symptoms that you complain about, in addition to those tests that are typically sensitive for MS patients, for me to assess, for example, processing speed and memory and executive dysfunction, then we will probably add to the battery of tests other assessments that could actually assess whatever it is that you're reporting as having, like decision making, or let's say you're not good at math anymore and you used to be an accountant. You want to be able to see where you're at in that area. We can do that for you as well. So unlike, a CT scan or an MRI that takes a picture of your brain and gives us information about the structure or kind of changes of your brain, the neuropsychological evaluation really tells us what is functioning right and not. So what you're able to do and not do. Okay, so we have written tests, oral, question and answers, nothing related to school or achievement. It's more neurological in nature to assess all of the cognitive domains that I mentioned before. So part of the evaluation is really to determine exactly where you're at premorbidly, or what your intellectual level is now or before. We do that by using your demographic factors, your age, your ethnicity, your handedness even, and your educational level and even occupation, to input a formula and come up with a Barona index, which is the best estimated IQ prediction for you, for your age, for your cohort. I cannot compare your performance to the performance of another individual that has a high school level of education if you do have a master's level or a bachelor's level. So we have to actually put you in the same category of other individuals with your same demographic factors. So when actually I interpret the results, I look at your premorbid intellectual ability. So if I see that you are not doing, as well, or I'll explain to you what that means in a minute, compared to where your intellectual level is, that is a significant finding for me. So as part of this evaluation process, we will actually examine your verbal skills, memory and learning, executive functions, attention and concentration, processing speed, deductive reasoning, visual constructional abilities, visual motor and sensory integration, and your emotional well-being as well, because that's an important component of the evaluation. This process typically takes about 2 to 4 hours, okay, depending on many other factors, your age, for instance, or how severe or not. If I determine that your deficits might be too severe from the initial consultation, then we might actually give you an abbreviated battery, just to find out how you're doing. So the purpose of this evaluation is actually to find possible problems with brain functioning, okay? To clarify or confirm diagnoses that are being investigated with regards to your memory or just overall cognitive functioning. To define your brain-related strengths and weaknesses, to guide your treatment for medical, personal, even educational and vocational. If you're still working and you want to change jobs, or you want to see if you have the capacity to continue to exercise the same job that you've been doing all this time, then we can help you make that decision as well. And also to document any possible changes in your functioning over time. Like I said, this will be an important aspect in where you have later on, if you do deteriorate, which in general we all tend to deteriorate cognitively. Starting from the age of 30, it's when we start seeing a normal age-related kind of decline. So it's important to have that baseline in your record in order for us to make comparisons later on when you do start to have more difficulties. So when we do have the results from this evaluation, then we have to determine if you really meet criteria for a neurocognitive disorder. This criteria was changed from the DSM-4 TR to the DSM-5, where now instead of using the word dementia, which actually had a very negative stigma associated with it, now we refer to it as a major neurocognitive disorder. So when you do hear the word major neurocognitive disorder, it's another word for dementia, okay? So depending on where you fall in that normal, it's a Berg curve. Let me see if I can point. I don't want to do something I'm supposed to. Yeah. So this is the normal Berg curve. So depending on where you fall in this table, which actually has a set of scores with regards to percentiles and Wechsler scores and standard deviations and percentages, we use this to interpret the results. So if you have more than 2 areas, more than 2 domains, not 2 tests, but 2 domains affected, okay, then we're already starting to look at a major neurocognitive disorder, and those areas have to be within below 2 standard deviations below your mean. So remember I referred to you before about your intellectual level. So if your intellectual level is within the high average range, which means that you're very, very smart, but now all of a sudden you're functioning within the low average to mildly impaired or borderline, then that would be a clinically significant deficit for you. Okay? For someone that has been used to functioning within the low average range and gets a mildly impaired score, that might not be so significant, okay? So a mild, and for a major, to make criteria for a major, you have to have impaired ADL, so activities of daily living. You have to see definitely an impact in your daily functioning at work or at home, like I said. So not being able anymore to pay your bills, or to go grocery shopping without the help of someone else, or at your job not being able to respond to the flow of emails that you used to respond before. So significant difficulties. A mild neurocognitive disorder, it's really having one or more areas affected, but those areas are within like one standard deviation below your mean for your intellectual level, okay? And before, in the DSM-4 TR, we used to have memory as a main component to be able to diagnose a mild or a major neurocognitive disorder. With the DSM-5, you don't need that anymore. So you can have any of those areas impaired and still make criteria for a mild or a major, depending on the classification or the degree of your deficits. So with complex attention, executive functions, learning and memory, language, perceptual motor, and social cognition, any of those areas may be affected. So what other factors do affect cognition? Many, including your physical symptoms as well. Tiredness and fatigue, for instance, would affect the ability for you to think and reason correctly. Your relapses, like Miriam mentioned before, that's another one that would affect your cognition. Medications, the ones that you're taking to treat your chronic medical conditions, may also be affecting. A common one would be sleep aids, especially the benzodiazepines. Psychological factors, for instance, emotional stress, depression, apathy. So depression is a big one because it's common in the general population and more so in patients with multiple sclerosis. And typically when we see a patient with significant symptoms of depression in our practice, sometimes I have to be cautious. We tend to be cautious in reading even the neurocognitive results because we try to rule out first a mood disturbance, and we try to address that first and stabilize your emotional symptoms before we even go ahead to suggest that you have a more significant problem with your cognition. So treatment recommendations for these would be individual psychotherapy. So we're very lucky now that we have a clinical psychologist with me working together with Dr. Psy.D to address your mood-related concerns and to help you with that as well, because medication may help with your symptoms, but you also need to process your feelings and your concerns. I find that with my MS patients, it's very important to have someone where you can come to and express your feelings, your concerns, help you to process acceptance if you're newly diagnosed, or even help you cope with the limitations stemming from your physical conditions or even your cognitive dysfunctions. At times might be frustrating, you're irritable, and you have mood swings. It's difficult for family members at times to understand what you're going through. So to have a person designated to actually help you through that process that is unbiased, that doesn't know you, and that would actually assess and treat your symptoms in a safe, supportive environment, is very important, okay? And everything is confidential. So we are bound to high ethical guidelines. So I encourage all of my patients to go through psychotherapy if possible in conjunction with any psychotropic medication management. I find it helpful even if you don't have any psychiatric condition. You don't have to be crazy in order to go to the psychologist, okay? Even to help you deal with the daily stress, it's good. Alrighty, so my recommendations, saying that it's actually to keep your emotional symptoms well controlled, as well as your chronic medical conditions, because like I said before, oftentimes a lot of the cognitive dysfunctions or even the disorders can be reversible. Let's say that you've had uncontrollable hypertension for a long time, or you've had infectious processes, anything that could be treated that we feel might be the reason why you have this cognitive dysfunction may be helpful, and the treatment is very easy. to do. And also having your multiple sclerosis, manageable with medication. It's very important to go to your follow-up visits with your MS neurologist to keep that. So the more you treat your MS, the more you're going to be treating and slowing down your cognitive dysfunctions as well. So sleep is very important. So I cannot stress this enough to my patients when they come to see me. Usually when I ask about sleep, very rarely I get an answer that we're all sleeping good. Either we get interrupted sleep or we suffer from insomnia, or sleep apnea, for instance. So all sleep is very important. So it's very good for you to practice a good sleep hygiene in order for you to be alert, have the attention that you need to encode information and retrieve it later on. Sometimes we think it's a memory issue, but it's really not. It's that you lack the capacity, the attention on a daily basis to really focus and be able to memorize information or even keep up with the daily tasks. Okay, so keep a routine. A routine is good. Share your cognitive problems with others, with your family members and friends. Sometimes it's very discouraging because I am the bad person in this picture because I assess what is wrong with you. I assess the cognitive problems and I tell you what's wrong, and then there is really limited things to do afterwards. Other than really managing and making sure that your medical conditions are well controlled. Sometimes I wish that we had an effective, for example, cognitive rehabilitation program that could really target these issues, but we don't have one just because, there's many factors into it that play into consideration, like age, for instance. Our brain does not respond to cognitive rehabilitation and stimulation the same way when we were in our 20s, for instance. We have limited brain plasticity. So we don't see a lot of results with cognitive rehab, but I find that if we make the appropriate lifestyle changes, we can actually make a difference, and also being aware about it. So you can tell your family members or friends, now they are aware, and maybe when you're having a conversation, they can fill in that word that you're missing from your vocabulary, and you don't have to feel ashamed or you're doing anything wrong. It's not your fault, okay? It can happen to any of us. So organize information, use compensatory strategies to really help you get through the day. Use a calendar, a daily planner to help you reorient yourself to space and time. Put things in the same place, like your keys and your cell phone, to avoid misplacing them. Repeat information. Repetition helps a lot. So when you meet new people, and this is a good cognitive exercise too for the brain, just repeat their names over and over again until you remember. You can close your eyes and remember their name. Make associations. So relate new information to things that you already know. Okay, so put information into context. It's very important. Involve your senses, so all modalities. Don't use just one. If you're reading, try to also associate information and use verbal. So express yourself what you're reading so that you can hear yourself, and you're also stimulating your auditory pathway. Teach others or tell them what you're going through so that you can raise also awareness about this, okay? Like I mentioned before, cognitive rehabilitation has been out there for some time. However, unfortunately, there's limited outcome data out there suggesting that it's really helping. And I think that one of the main factors is obviously age, and like I said, our ability, the brain's incapacity to do plasticity anymore. When you're younger, you tend to rehabilitate cognitively pretty fast. We see that with kids that go through traumatic head injuries or even a stroke at an early age, but unfortunately, age is a big factor. So all we can do is really rely on compensatory strategies, like using, like I mentioned before, personal organizers, alarms, written reminders, directions, phone logs, anything that can help you. Pace your activities to manage your physical and cognitive fatigue, so take frequent breaks. Telecommunicating, for your job, if that's an option for you. So making your life easier. And overall, my general recommendation, like I said, is really to maintain a healthy and active life, including physical, mental, and social aspects. So making those lifestyle changes and incorporating them in a daily basis, it's what I really recommend. Exercise has proven to be the only one effective remediation for cognitive dysfunctions, as well as how it helps with your physical and medical conditions as well. So it's particularly aerobic exercise, 3 to 4 times a week, at least for 30 minutes. It's supposed to help with your cognition as well. And like I mentioned before, having a good sleep hygiene, it's important. Alrighty, thank you very much. So
Awesome.
Now we're going to open questions.
Awesome. So again,
Go ahead.
left side and right side of the room, and we need a microphone to them all.
How are you? One thing that I saw in one of the slides that you said it doesn't affect when it comes to the long term. Why is it that it affects the short term? Because I have the problem. It's affected my short term, but then I could remember things from 30, 40 years back, like if it was just yesterday.
Yeah. So it tends to affect more new learning because it's our ability, again, to process new information that is deficient. So those memories that are from way past that are already too ingrained in your temporal lobe, and what we find is that the circuit that is actually damaged or having trouble with is that pathway from the frontal lobe to the temporal lobe that it's affected. And oftentimes, like I said, it's more due to an executive dysfunction than anything else related to the temporal midbrain kind of instructions that will be signaling more of like a neurodegenerative condition. So that's why. Yes?
Wait, over here, please. Okay, over there, please. No.
Hi.
Hello.
Hi. I don't think all of us here have gotten an actual thorough neuropsychological evaluation. Perhaps some of us have been blessed to have done it at some point in our lives. My question is, how often within the course of our lives, perhaps with MS or after our diagnosis, is that you recommend for us to, let's say, have one done? You know how we have to have an MRI every so often to kind of take a look at how we are either progressing, the MS is progressing or not. How often do you think we should do it, or what should be the red flags to tell us when should we get that done, perhaps?
That's an excellent question. Yes. So I have to actually say that Dr. Subay is excellent in this. So he has that as part of his comprehensive MS care for his patients to undergo just as normal workup, a neuropsychological evaluation. Just like I said before, it's important to have a baseline of how you're functioning. That also helps him to know if you're having significant cognitive difficulties from the very start of your condition, or if you're already having them when you're coming to him later on. So it's very important. So you're actually the best advocate of your cognitive status. So it would be very important for you to actually monitor your symptoms and be able to determine if you're having significant cognitive difficulties or not. So after you undergo that first baseline neuropsychological evaluation, for the most part, I don't really recommend for you to undergo another one unless, in a short period of time right after, unless you are noticing significant changes. If you notice that you're doing poorly or you're doing worse than how you were when you went for that neuropsychological evaluation, then that would be appropriate for you to get another one. If not, then more or less I would think, in a window of like a year, 2 years, 3 years, depending on if you go to your MS neurologist and you don't report any cognitive changes or any other changes that I have to know about or that your neurologist is concerned about, then it wouldn't be indicated, clinically indicated to undergo another one of these evaluations. But if you're having a significant change after let's say you went for an evaluation today, and then a year from now you notice that there is really no improvement, and you continue to have deficits, and you want to find out why. And now one of the factors that we were considered was depression, and now you feel that your mood has been stabilized, you have been in psychotherapy for a while, and you still have these cognitive deficits, then go ahead and go. So a minimum of a year would be for retesting.
Before I go to the next question, I have a question for you too. For all those that are seeing other neurologists other than Dr. Soubey, can they still use your services at Memorial?
Yes, of course.
My question is regarding the short-term memory. Lots of times, you said before to have a safe place, but Linda, she lots of times she'll put something down and forget where the safe place is. Is that a cognitive decline?
It depends. So
everything else is all right, basically.
It happens to me too. So, but no, what I said is really to have a designated place to put these common things, like the cell phone and the keys. And it's better if you know that you put it, in a drawer when you come home, then always put it in that drawer in the kitchen when you come home. Yeah, it's very common with the cell phones nowadays because we're always with them at all times. But that's what I meant when I said a designated place, to especially the keys. Yeah, you're welcome.
You done? Doctor, thank you for what you're teaching us. I really appreciate it. But I have a question that's a little confusing to me. A lot of the things that you're speaking about, I see in elderly people. That happens, correct? Cognitively, they forget things, they forget names, they forget places, etc. If we suffer from this as MS patients, does this mean it can get only worse as we age?
Not necessarily. After you undergo the evaluation process, then we really have to look at what are the etiological factors causing your cognitive difficulties. Let's say it's emotional. Let's say it's your medical conditions that are not being controlled yet. So we have to look at the underlying factors before we make a decision as far as what could be causing. If it doesn't have to be necessarily progressive. The cognitive changes or deficiencies that we notice with MS tend to be progressive. So it goes along with your disease. But it takes a long time. So it's
the reason I use the terminology progressive is because I see a lot of these symptoms in elderly people that do not have MS.
Exactly.
So I'm wondering, if MSP patients have this, does it get progressively worse, or does it just come to all of us as we age, period?
So the characteristic profile for an MS patient compared to another patient that suffers from something else, let's say a stroke, or another patient already having significant difficulties that might be suggesting a dementing process, for instance, it's different than what we typically see in an MS-related profile. So even though those elderly patients might be reporting forgetfulness or short-term memory loss, it tends to be different. I expect a lot more memory impairment in those patients than what I expect in the patients with multiple sclerosis. And like I said, the cognitive profile is a little bit different, where we see more processing speed issues and executive dysfunctions than I expect memory loss. And then if that's the contrary, then I am looking at other factors and other conditions that might be underlying.
So that being said, if MS patients have these symptoms, and we address them, can it help patients not get any worse as we age?
Yes.
If they're addressed earlier?
There is treatment for memory loss with, for instance, the most common one is with anticholinesterase inhibitors. So sometimes we make that recommendation to the neurologist. or I leave it up to Dr. Subay or your neurologist to decide what medication might be best for you. Since you're also taking other medications, we have to be careful with what we recommend, given that there could be drug-to-drug interactions. But yes, we can give you medication to slow down the progression of the memory loss. However, like I said before, it's very important for you to maintain the MS controlled with the MS disease-modifying therapy. So exactly. So it goes, hand in hand. The more you keep that well controlled, the more you're going to be controlling the cognitive dysfunctions as well. You're welcome.
Last question, right here.
Yes.
Yes, one question that is mind-boggling to me, because when I have my cognitive issues and I go see my specialist about it, why do they always think that I have maybe epileptic seizures? Why do they compare cognitive with epileptic if you're not even epileptic?
So I really don't know your clinical presentation, but it's very different. So epilepsy, it's a seizure disorder, and it's very different from multiple sclerosis. So again, the cognitive presentation for a patient with epilepsy, it's very different from a patient with multiple sclerosis. So I'm not sure why you're being made that suggestion. But I suggest for you to meet with a neuropsychologist and to undergo an evaluation so that you have a better idea. Okay?
Let's give Dr. Broz a hand.
Thank you very much.
Thank you for coming here today. I'm sure that if anybody has questions for Dr. Broz after the program, that she might stick around and be there for you. We want to thank everybody for coming here. We want to again thank Memorial Neuroscience for partnering with MS Views and News to do this program. And of course, I have to thank all of you, because we couldn't do this without you. Thank you.